Hello and thank you for listening to the 5th season of the ISTAART PIA Relay Podcast, brought to you by Dementia Researcher. ISTAART is a professional society and part of the Alzheimer's Association, representing scientists, physicians, and other dementia professionals active in researching and understanding the causes and treatments of Alzheimer's disease and other dementias. In this 6-part series, we have members of ISTAART professional interest areas taking turns at interviewing their colleagues and being interviewed themselves, with the interviewee going on to be the next episode's interviewer. We're sure you've listened before, so you know what to expect. We'll be releasing one of these podcasts each day in the build-up to the Alzheimer's Association International Conference, which this year takes place in Philadelphia. Through the series, we hope you'll learn more about some of the amazing research happening in different fields of discovery and about the great work taking place in the ISTAART PIAs. Thank you for listening.
Hello, and thank you for joining this final episode of the ISTAART PIA Relay Podcast, brought to you by Dementia Researcher. My name's Keir Yong. I'm a Dunhill Medical Trust Senior Research Fellow and a Principal Research Fellow at the University College London Dementia Research Centre, and I work on the atypical AD professional interest area as the Vice Chair. Today, I'm delighted to be talking to Professor Arlene Astell. Hi, Arlene. Could I begin by asking you to introduce yourself and tell us which peer you're involved with?
Yeah, hi, Keir. Thanks so much. I'm really excited to be here. My name is Arlene Astell. I'm currently a professor of cyber psychology at Northumbria University in the UK. And I'm also director of the Dementia Aging Technology Engagement Lab, or the DATE Lab, at the University of Toronto in Canada. And currently I'm the chair of the Non-Pharmacological Interventions PIA.
Thank you. Could you give us a flavour of your own research and also what initially brought you to dementia research?
Mm-hmm. Okay, well, I've been doing it for a long time, so I'll try to summarise. I actually came to dementia research through my initial experience after I graduated with a psychology degree, and one of my first job was to interview people in a large mental health facility that was about to close, that was being closed down, and I got to meet people living with dementia, and I was absolutely fascinated. I wanted to understand what had happened to them, what was happening to them, what had brought them to this sort of being in this hospital, and it just led from there. And I went on and did a PhD and have worked with people living with dementia ever since. So unlike some people who come to it through perhaps family or personal experiences, it was really just meeting people sparked my interest, and it's still very much there. I think there's so much we still don't know. But my actual research, so as I said, I have a psychology background, and for me, I think that frames certainly my approaches and why I sit very much in the non-pharmacological interventions approaches, is that I approach things from a psychological perspective, which means understanding the relationship between cognition, which of course, since the labels were redone to neurocognitive disorders, we're recognizing that dementias are, cognition is a huge part of it. So to me, that interrelationship between cognition and behavior. So behavior is what we see people doing, and that's mostly how people understand dementia, is what they see, how the problems people have. But really, it's the cognitive underpinnings for their behavior which interests me as well. So I think having that framework helps to really bring that lens to understanding the challenges that people face, the changes that occur over time, and the impact that has on their lives. So when I think about the types of research that I do, it's very much about seeing what those challenges are and what we can do either to prevent them if possible, or mitigate them, maintain people's abilities for as long as possible, but also mitigate some of the impact which it can have on their personal relationships, their confidence, their ability in social situations, their loss of comfort, their loss of skills. And, dementia affects the whole person. And we talk about people living with dementia. So there's so many aspects of a life with dementia that really needs support and assistance. And also that changes over time. So it's a very complex situation that people are in.
And that resonates strongly with other podcasts on these series, like the Partnering with Research Participants PIA, where, to paraphrase, I think it's fair to say that a large majority of people living with dementia would consider some of the areas you talk about really to be core to their experiences, whether it's some of those cognitive symptoms, whether it's the behavioral manifestations, or, as you mentioned, some of the implications for people's day-to-day independence and a desire to maximize people's independence.
I mean, I did actually a very experimental traditional sort of PhD, which was psycholinguistic based. So I did lots of experiments about speech production and followed that very traditional path. But what was fascinating was realizing that the people I worked with, and they were primarily living with Alzheimer's disease, and most of them had already reached quite a sort of progressed stage. So they were mostly living in care settings, or, as I say, in the hospital that I worked with. But what was interesting was there were patterns in the impact that Alzheimer's disease had on their speech and their communication. So it wasn't like blanket loss. In fact, there was lots and lots of retained abilities, knowledge, aspects of communication. And I thought that was actually the really important thing, because that meant a sort of a different way of looking at it. That instead of just going, well, it's all downhill, it's progressive decline, everything disappears. It was more, okay, let's try and understand why some things do go early, why some things are better retained. What can we do to leverage those ones that are well retained and mitigate or find ways around the ones that are more at risk or disappear more quickly. And so I was very fortunate that my very first research funding was actually creating a conversation support for people with dementia. And this really highlights this sort of bringing this approach of understanding the profiles of what is spared and what is impaired, and trying to use that to improve the situation for people. So the problem we were presented with was, well, it's very difficult for people to have conversations because they can't remember the answers to things. They can't remember, their families come and see them and they say, what did you do today? And they don't know what they did today. But what we realized was, actually, there's not just a problem with memory, but there's a working memory problem. Because if you're having a conversation, you've got to remember what's been said in the previous sort of turns. But the problem people we were working with seemed to have was they couldn't keep that in mind. It's whatever's here and now. And this is sort of nearly 25 years ago. So, I'm not saying anything that people perhaps don't know now, but back then, we saw that was what we should be tackling. So we created a touchscreen computer system, and whatever was on the screen was what you were talking about. Or it could be some music, you could sing along, you could be watching a little video clip and talking about it. And that had a transformative effect on the conversations, because suddenly the cognitive abilities of the people living with dementia wasn't the issue anymore, because they're doing this shared activity with one or more people. They're chatting about things, they might be singing, spontaneously getting up and dancing. And suddenly the whole thing was changed. And that was really revelatory to me and the people I was working with, because it suggested we can do things to address some of these challenges that people are facing, and not just sit back and go, well, it's all going to be downhill. I think the other thing I would mention is we used some very early touchscreen technology, so way before smartphones and so on. This is 2001. But they were very accessible, which I think is why we've seen them become so popular globally anyway. But that's another key thing. It's recognizing that people have the cognitive impairment they clearly have, creates a barrier to some interventions because of the cognitive load for them to learn how to do the intervention. And I think that's another really key thing to keep in mind when we're designing these non-pharmacological interventions.
Well, that's a great prompt to bring us to what you consider to be very current areas for your research field. What are the current hot topics and what you feel are, again, particular exciting areas of development?
Yeah. I think it's very interesting. And within our PIA, we're very conscious that we've actually become a very broad, we have a very broad reach and a very broad range, which is definitely a strength. And we have a very broad membership. But it also means that when we're doing our events and activities, trying to sort of reach everybody is quite a challenge. But some of the areas, when we were established, one of the key things that was highlighted was the potential for lifestyle interventions, things that could reduce risk, as well as interventions to support people to live as well as possible with dementia. And obviously, in the last 10 years, we've seen such a rise in the lifestyle interventions, and also the rise in other peers that are starting to look at some of these things. So there's obviously the nutrition one, for instance, there's a sleep one. There isn't currently a physical activity one, but in our peer, we have people who are looking at all of these together. So it tends to be people doing those sort of multimodal interventions, and that's obviously something that's really still developing. I think as well we have a lot of synergy, and we have membership who span other peers as well, like the SCD group, because obviously SCD has increasingly become a target for modifications and interventions. Another area, though, where we've certainly seen a lot of interesting work is in the neuromodulation, again, which is more in the preventive end of things. And in our year in review, not in 2024, but in 2023, for example, there was a lot of interest in the evidence that's emerging. And really the questions are always, when can we get this? Where can I go and have this done? And I think that's one of the interesting challenges that we face, is bridging that gap from the research to the real world applications. Because what it shows us, whenever we do these public events or events that attract not just researchers, but lots of clinicians and lots of frontline workers who are, engaged in this. They're looking for, what can I tell my clients to do? What can I offer my patients? And that's where I think the non-pharmacological interventions particularly are very popular, but people want something they can pick up and say, I can tell my patients to do this, or here's an activity. And I think that's one of our, whilst there's great progress going on, there's also these challenges of actually, how do we get them to people? But I would also contrast that when we did our year in review this year, it was from a completely different aspect. And it was actually about technologies, but ones that support people at home, that support caregiving, that support that dyadic relationship, and various innovations that are supporting that. So I think those highlight how the scope of non-pharmacological interventions is really blossoming. And, there are so many areas where the value and the potential are being recognized. That makes it a very exciting time. So, yeah, that's just some of the things that we're doing.
And you mentioned again the broad scope of the non-pharmacological interventions PIA, and you also mentioned some again of the challenges regarding implementation and effectively health system capacity. So one following question I have is, where do you see the role of, say, more public health research, or perhaps more, again, research relevant to influencing policy sitting amongst the peers? Do you feel this is something which is particularly relevant to your peer, or something that sits between a number?
I do actually. I think. I mean, I'm more familiar with the statistics in the UK, but I guess the breakdown is similar in most countries. But if you look at the cost of dementia for any year, almost half of it is family care, is the cost of families. In the UK, the biggest proportion is social care. And I know not every country has exactly the same system of social care, but healthcare is the very smallest bit by far, 10% or less of the cost. And I think that is now that might be different in the US, which is an insurance-based system, so it's very different. But in the UK, health is not the dominant provider for people with dementia. And I think that is really important for understanding the potential idea of a pipeline, because when it's pharmacological, people understand that pipeline. You go to the doctor gives you the medication or infusion or whatever we're talking about. If it's not pharmacological, first of all, the evidence base often, these large scale RCTs are not as prevalent, haven't had, there aren't so many of them. And there are the what would I call it? The processes for initiating and disseminating and implementing these is much more fragmented in some ways. The standard that's required and the evidence base that will make the commissioners say we're going to roll this out for everyone. If you look at, as I say, in the UK, there's only one non-pharmacological intervention that was recommended. It might be two now, but they're, it's very small in comparison to the numbers that exist and the research projects that are ongoing. And I do think engaging more with policymakers around to raise their awareness of how the needs, these complex, comprehensive needs of people living with dementia, and the availability of the range of interventions, but also to understand from them what would give them comfort enough to commission or support the rollout of these. And also that has workforce implications, because currently we don't have, certainly in the UK, maybe other countries do, but I'm not aware particularly of this, but like a role that is supporting people living with dementia, particularly to access all these different elements of their life. So I think, like, who would do these? I think there are many questions. So for researchers, and this is not meant to sort of scare people, but it's more like the reality. Doing good work, getting good, exciting results, publishing it, presenting it, does not mean it will be adopted when in this non-pharmacological space. And I think that's something collaboratively we need to engage with. We do, because there's lots of really promising things, but the majority are not getting out there.
And it certainly sounds like there's a lot of learning that could be done through international conversations facilitated by things like ISTAART, where I may have misunderstood this, but from participating in one UK and Brazilian dementia care workshop, my understanding was, at least in some parts of Brazil, there were some professionals who I think might fulfill a role that you touch on, who essentially are working within or linked to primary care settings, but again, working between families, general practitioners and the third sector. But my understanding was, again, it was a family who were taking on the greatest in terms of providing care, which I think is a recurring feature of a lot of systems.
Absolutely. And it's really interesting to hear that. I have heard some innovative things happening in Brazil. I wasn't that particularly, but I also think it does raise this question as well of who will pay for these. So if they are provided through the healthcare system, then that is attached to a budget, and then presumably somebody to deliver it. But I think these are the questions that we definitely need to be asking now, because with the global sort of spread, in the sense that there's far more countries who are starting to grapple with dementia for the first time, they will be also looking for, well, what are the things we can offer our population? And if there are no sort of very clear models, well, this is the pharmacological efforts, and these are a set of non-pharmacological that you can have, both for the individuals and their families who as you say, provide the bulk of care, then that's another aspect. And I think for us, either the peer that I'm currently chair of, or a number of peers who are working in allied challenges, maybe we should be leading that conversation and bringing those players together. Because whilst it's fantastic that, there's so much focus now and effort and funding going into the sort of exploring the potential pharmacological solutions or things that could help, the people living with dementia still have very multiplying needs, and they are very costly to economies if we just carry on as we are.
So on that note, so this week saw FDA approvals of donanemab for the treatment of Alzheimer's disease, and this follows their approval of lecanemab last year. So I'd just like to get your thoughts on where you see the role of non-pharmacological interventions in perhaps complementing the anticipated increasing access to, again, disease-modifying therapies targeting Alzheimer's disease.
Yeah. I think it's a really interesting question. And obviously, whenever you have these, new approvals and the media coverage raises people's hopes and expectations, and they want to know, can I just nip to the doctor now and get this? So I guess any long-term impacts, we still have to see how this will roll out and what it will do. But for people who are living with dementia, the aspects of their lives that these new compounds could address and how they will address them, I think we don't really know enough yet to know exactly what it will look like in people's everyday life. So being able to still provide tools and resources and activities and strategies for people and their families to live with dementia, because it seems where we are now that they're not going to be, we're not talking about people being reversed, their condition going away. So, and I think we also have to manage those hopes and expectations. But I don't know. Maybe, I'm not best placed to do it. But I know from previous things, people get very hopeful. They think, oh, it's fine. I'm just going to get this drug. And I think there is a lot of anticipation, but what it will, but maybe the good thing is it raises awareness. And so perhaps that does open more channels for increasing availability of additional activities and things to help people manage with the changes they've already experienced, for example.
And presumably that might be tied into some of the discussions you were having about things considered at a sort of service or health system level as well. Hopefully there might be some complementary conversations regarding capacity in the system.
Absolutely, because actually that is a potential danger that we have to be aware of. That health systems think, oh, we've got these drugs now, we've got compound, we can just we're done with, we're sorted, and that's definitely not, because we haven't even really got going with, and also we have to think about there are multiple types of neurocognitive disorders, and many of them have very limited attention, as you know from the PIA lead, so but we're far from done and dusted, and I think there's a danger with creating that impression that, oh, approvals will resolve that, but rather keeping the effort going and thinking about all the people. For instance, I do, and again, this is sort of relevant in our peer, because people with young onset dementia who have a multiplicity of challenges of living with typically not memory-based problems and losing their employment, the financial impact, trying to support, they've got kids, and there are many people affected. So when we're thinking about medications, we have to, I think, getting that messaging that this is part of a picture, as are non-pharmacological supports as our formal services. But living with dementia is a very complicated scenario for people.
So going back to your peer specifically, how does the work of your peer support your area of research?
That's an interesting question. I was trying to think what I wrote when I did my statement to put my hat in the ring to become part of the executive. I guess for me, the peer, because it is very broad, and as I said, when I look at our actual underpinning statement, which talks about a biopsychosocial framework, I think for me it aligns with my approach of relating, as I said at the beginning, our understanding of cognition and how that is related with behavior, but also that the impact is more than we can just see. It's the broader ripples that it has around the person. So for our peer, we're very much a sort of a largish group that brings different perspectives, different ideas, different types of methodologies. We're very sort of broad, very quantitative, qualitative, mixed methods. Very, it is a very broad grouping, but there are things that unite us. So, for instance, one of the things we're particularly interested in at the moment is what are meaningful outcomes, and that has always been an objective in our peer is identifying those, and obviously that involves working with people with who are living with dementia and those close to them, but also, and this is where I think it comes back to that evidence base for commissioners or health services, what can we demonstrate this is going to do? And I think with the non-pharmacological interventions, especially for people who might be have been living with the condition for a while, what does a positive impact look like? What is a positive outcome? In some studies, it may be some improvement on measures of cognition or some other, but it could be a functional ability, or it could be maintenance or slowed decline. And all of those can be positive depending on the context. So for us, our peer is very much about having those sorts of discussions about the different ways we can identify meaningful outcomes for people. Also, and this was another original aim, and it speaks as well to the evidence base, but improving the design, implementation, evaluation, and reporting of trials of NPIs. And I think when I was mentioning earlier about the multimodal interventions and those studies, I mean, they've sort of addressed some of that by having these very, extremely tight, robust designs, large numbers, etc. And that is, I think, been positive for raising the bar, but also raising awareness of the power of non-pharmacological interventions. So I think we can benefit from that. I think if we look at non-pharmacological interventions, when people are more further along with their life with dementia, what a positive intervention looks like is something that's a bit more nuanced. And I think as well, because we have interventions for caregivers too, and often they are these dyadic approaches, what are positive outcomes for caregivers, for family members particularly. So all of those things, there are obviously ongoing aims in our peer. I think they are also really important themes for early career researchers, students, people starting out in this domain, to have some sort of an appreciation of the context.
And it's very encouraging again to hear the voices of people living with dementia again, and people close to them being front and center in thinking about what outcomes are relevant to their experience. Can you tell me a bit more about how your peers organize, and also a bit about your executive committee? Also, are there any opportunities with to collaborate with the other peers?
Yeah. So I guess we have a fairly standard structure. We have a chair, deputy chair, who will then become the chair. We have our conference chair, a comms chair. We have someone who leads on social media, who's very good at doing that. And we have student rep, postgrad rep, postdoc rep, and then some ordinary members. We're quite a small committee, and most people are new in post for this year, except for me. So we have been people have been getting to grips with their roles, because a lot of them are very early career, researchers, which is fantastic, who are bringing a whole range of different knowledge, experiences from different countries. We're a very global committee and a global peer, with our membership is very, spread across the world. In terms of opportunities for collaboration, yes, we have some that we already have underway, like with the Tech PIA, with the SCD. Some of these are through our members, but also ones we're exploring. So you mentioned the one with people with lived experience, and we've also explored the disparities. There's different ways we could collaborate, but I think as well, there are many opportunities within the peer itself as well for researchers who have ideas for areas to focus on, white papers, reviews that they would like to get involved with as part of the PIA. And we're very much encouraging that, and as part of what our activity at the PIA Day will be in Philadelphia.
And on that note, so what has your peer got planned for its peer day? Are there any other things that you have in store for this year's AAIC or over the coming year?
For peer day this year, we're doing a World Cafe session. And the reason is our peer has been established for quite a few years. And in that time, there's one of the key areas was looking at, the potential of risk reduction and so on. And we've become aware that sort of activity is increasingly of interest, and also in part is emerging in other peers, which is fantastic. But we also want to, in a sense, revisit some of the original aims, some of which I just said are still very current, but also to engage with the early career, the PhD students, the postdocs, the sort of early career academics, to set those priorities, to examine the ones we had from the start, and then where we want to refresh, what are new ones, and really set that agenda for the coming years, which could include, as I said, sort of white papers and so on. We're also planning an education session, which will be focusing on the meaningful outcomes as one area. And we're also looking into applying for sort of a one-day workshop or conference to really look at this whole space, and perhaps based on this discussion, including the piece around how to influence policy. What do you need to do to increase the uptake of non-pharmacological interventions? Because that is definitely something that individual studies and researchers can experience as a bit of a barrier. So I think that would be great as well, to engage with the association and others who could have some assistance in thinking through what this needs to look like, because raising awareness is clearly a really crucial factor. And just to also mention, I mean, I guess like many peers at the conference, we will have our posters awards and so on. So we have our team of PhD and postdoc reviewers, and I think that's actually really exciting. And I think hopefully bringing people together at the World Cafe, which if you've ever been to one, they're quite fun, they're quite frenetic and quite busy, people scribbling all over like tablecloths or sticky notes on boards and so on, and then someone has to make sense of it afterwards. But it's really a space for our membership to have their voice. And I guess for people who can't be there, they can share their thoughts electronically.
And over the previous years especially, we've seen a lot more opportunities for people to engage, even if remotely. Really, it sounds like it's a very valuable opportunity.
A lot of times in other settings, we use these digital whiteboard systems, where you can have your remote sticky notes. So it's possible we can have some people doing the same activities, but joining it remotely, which would be great, because we want as many voices as possible to contribute to this. And I know that now there's so many peers, we're all competing, there's 5 or 6 on at the same time. We only have an hour. But, I would definitely encourage people who are members of this peer or are thinking about it to come along and share, give voice to what's important to them and what they want us to prioritize in the coming years.
Well, thank you. And I think that brings us to our final question, which is, why would you suggest listeners sign up to your peer?
Well, I hope I've given a flavour of the breadth of our interests and our expertise and our ambitions. I think for people who are not currently working in the sort of more biomedical space, but are actually either working with people living with dementia or working in memory assessment clinics or services in the community or in any other setting, and are interested in supporting people, supporting the families of people living with dementia, and really addressing some of the very knotty challenges that still exist. There are plenty of challenges still to be tackled, but also that we're a friendly, supportive community. We have this diversity of approaches, of knowledge and different methodological expertise. So people can come along and pair up with more experienced people, get mentorship. There's lots and lots of different ways that people can get involved and gain support through our group, through our peer.
Thank you so much. So that's it for today's podcast. Thank you, Arlene, for taking the time to join us today. And thank you for listening. Thank you for listening over the 6 shows. I hope these ISTAART Peer Relay podcasts have given you a sense of the scope, breadth and depth of the peers and how they might help you expand your network and to find new collaborators. You can find profiles on myself and my wonderful guest, Professor Arlene Astell, and information on how to become involved in ISTAART on our website. You can find that on dementiaresearcher.nihr.ac.uk and also at alt.org/ISTAART. You should also check out the new ISTAART podcast, which is available on the Dementia Researcher website and the podcast apps. We're very much looking forward to the AAIC conference, so if you haven't already registered, please visit alt.org for more information, and please come find us and say hello if you're joining in person. Finally, please remember to like, subscribe, and to leave a review of this podcast through our website, iTunes, Spotify, and SoundCloud, and all the other places that you might find podcasts. My name is Keir Yong. Thank you so much for listening.
The Dementia Researcher podcast was brought to you by University College London with generous funding from the UK National Institute for Health Research, Alzheimer's Research UK, Alzheimer's Society, Alzheimer's Association, and Race Against Dementia. Please subscribe, leave us a review, and register on our website for full access to all our great resources. dementiaresearcher.nihr.ac.uk.